Hi everyone, it's Sue and I'm going to start this lecture. I hope I make it all the way through endocrine issues from thyroid to diabetes and chronic complications. And there is a separate recording for acute complications, but you know what, I'll just see how it goes. For all of us, I think there's lots of changes, and for me, part of that is having my kids home. So they're out jumping on a trampoline and I hope I can make it through. So let's move here. Oh, now remember we've covered all of this in class, but I'm going to go over it again. So disorders of the thyroid range from complete hypothyroidism to life-threatening hyperthyroidism. And right in the middle, you see euthyroid, completely neutral. On the right-hand side, you see hypothyroidism characterized by T3 and T4 levels that are out of whack, in which case they are causing a decrease in the amount of activity that is generated from your thyroid, to myxedema coma, which is a life-threatening coma caused by profound hypothyroidism. We'll talk about all of these. On the left side, we see a hyperthyroidism, so a revving up of that thyroid, which causes a lot of significant consequences to a variety of systems in your body, including your cardiac system, to then that extreme hyperthyroidism called thyroidtoxicosis, a critical life-threatening hyperthyroidism. And just as a reminder, that continuum is really important to keep in mind. Extreme hyper through a pathological but not extreme hyperthyroidism, to euthyroid, which is neutral within the normal range, to hypothyroidism, and then extreme hypothyroidism. Reminder again, what is the thyroid involved in? It's critical for the regulation of energy metabolism, for growth and development. And it's important to recognize, as we talk about in the next few slides, disorders related to your thyroid, that often what we see is enlargement, benign and malignant nodules, inflammation, and then that hyper and hypo functioning of your thyroid. And that's a classic photo. This is a classic photo of goiter. Goiter is a very old-fashioned term, but we still use it. Hyperthyroidism occurs more often in women than in men, and with the highest frequency in persons 20 to 40 years old. The most common type of hyperthyroidism that it's a term you've heard of, I bet, Graves' disease. Other causes include nodular goiter that's toxic nodular goiter, thyroiditis, so an inflammatory process in our thyroid, exogenous iodine excess, so you've got too much iodine through your diet or exposure, a tumor in your pituitary, because there is a feedback loop. Tumors in your pituitary can lead to that excessive inflammation and growth, and actually cancer of your thyroid. Now, I'm just going to go over Graves' disease for a second here because it's important. It's autoimmune in origin, and we really don't know the process. Sort of like until recently, we didn't have that great a handle on diabetes. We knew what happened, but we didn't know what the etiology it was. What was the source of that change? In Graves' disease, what we see is that diffuse thyroid enlargement, so your thyroid becomes enlarged, and an excessive amount of that thyroid hormone secretion. Things like insufficient iodine, infections, stressful life events, and sort of a genetic predisposition, somewhat like what we suppose with diabetes, that genetic predisposition that controls immune responses and metabolic abnormalities seems to cause Graves' disease. Interestingly, so what we know is that in identical twins, 50% of identical twins both have it, and that tells us that it seems to be this combination of genetic and environmental components. In Canada, Graves' disease is really predominant. 90% of the cases of hyperthyroidism are from Graves' disease. And in those cases, your patients have developed antibodies to the TSH receptors. And these antibodies then attach to the receptors and stimulate the thyroid gland, and it just keeps churning out T3 and T4. And excessive release of those hormones leads to those clinical manifestations of thyroidtoxicosis, right? So it's characterized by, just like many autoimmune diseases, MS is another good one, by exacerbations and remissions. Exacerbations and remissions. regardless of whether you have treatment, you tend to go through that process. And it's an interesting process because ultimately we've churned out all of that T3 or T4 or both. And at some point, there is just such a profound overuse of that thyroid that we have destruction of thyroid tissue and then hypothyroidism. So in Graves' disease, we go from extreme hyperthyroidism to hypothyroidism. In this picture, you're going to see a couple things, that exophthalmos, so those eyes that are sort of bulging out. And that happens because there's this infiltrative process in the ophthalmopathy that is happening. So it is an infiltration that leads to this ophthalmopathy. And it seems that it's a lack of drainage from the orbit that caused that problem, and some fatty deposits build up. So here we're going to look at goitre gens, right? So things that can cause goitre. There's thyroid inhibitors, so iodine in very large doses. And again, typically that's going to be some kind of environmental exposure. Tapazole, which is a medication, and later we'll talk about tapazole because we use that therapeutically when someone is hyperthyroid. And we also have propylthiouracil. Again, a very, very old drug, but we can use that. Drugs that we see this as a side effect, amiodarone, lithium, which we use for typically bipolar disorder. Salicylates is a common one, and sulfonamides. And then there's foods, and we just watch with our patients and make sure they're educated around those kinds of foods. You're going to see, I'm not going to read them all for you. So let's talk about thyroid nodules and thyroid cancer for a sec. So when we feel a thyroid nodule, that's a palpable deformity in that thyroid gland, and it can be either malign or it can either be benign or malignant. Luckily, more than 95% of all thyroid nodules are benign, and your risk for developing these increases with age. So when you have those benign nodules, they're typically not dangerous, but the problem is as they grow larger and larger, they can compress your trachea if they become too large. So they need to be assessed and evaluated every year. Thyroid cancer, on the other hand, is the most common type of endocrine-related cancer. It's estimated, I think, in Canada, around between 500 and 600 cases. And I think we have data that's not too distant, but not too recent. So maybe data that's about 5 to 7 years old. The majority of thyroid cases, and an interesting gender-based disease process, is in women. And the primary sign of thyroid cancer is presence of that painless palpable nodule or that enlarged thyroid gland. And most of the time, patients and healthcare providers find this on inspection. Important laboratory findings in the diagnosis of hyperthyroidism are the dropping or decreasing of TSH levels and the elevating or rising of free thyroxine, that's FT4, total T3 and T4, right? So the elevated free thyroxine levels become larger than the total T3 and T4. It's really important that the free T4 is a better measure. So we also can look at T3, T4. We often measure those, but the better measure when we're looking for lab findings in hypothyroidism are the TSH levels and the free T4 or FT4. What else should I say to you? The radioactive iodine uptake test is an important differentiation when we're looking at Graves' disease versus other kinds of thyroiditis. A 24-hour radioiodine uptake in the client with Graves' disease will show sort of diffuse, homogeneous uptake of 50 to 80%, and that shows that we've got increased thyroxine when we've got Graves' disease. But when a client has thyroiditis instead, we show an uptake of only about 20%. So we inject some radioiodine, we allow for a 24-hour period to pass, they do a scan to see how much uptake there has been. And then we look at the percentage, we can calculate that. The percentage of uptake tells us whether we're looking at Graves' disease versus thyroiditis. So it's really critical that when we're thinking about thyroid cancer or even thyroid inflammation, we're always paying attention to the location of that, right? So when we're talking about thyroid cancer, we typically are looking at surgical removal as opposed to any other treatment, although there may be adjunctive treatment, but almost inevitably there's going to be surgical removal if it's cancerous. And that can range from that unilateral lobectomy to a total removal of the nodule, unilateral total lobectomy, removal of the entire thyroid. So that would be bilateral lobectomy. And there's a huge range. Thyroid therapy can be used as the primary treatment or as palliative treatment when it's metastatic. So when it's metastatic and you're not looking to cure, but you're actually looking to comfort measures and or prolonging life, we may be thinking about thyroid radiation therapy, and that can be adjunctive therapy as well. Important that we always have an airway kit around, right? And because when we're looking at large goiter and other kinds of things, that non-cancerous tumor can, again, increase the pressure on our airway and actually compress our airway. There may be a thyroidectomy in patients who have even a non-cancerous tumor. So important to keep that in mind. When doctors do that procedure, one thing to keep in mind too is that if too much of the tissue is taken, not accidentally, but if too much of the tissue has to be taken depending on the situation, then the gland is not going to regenerate after surgery, and a patient ends up going from hyperthyroidism, having to have surgery for that reason, and being hypothyroid afterwards. Here's a little YouTube link. You guys can all take a look and see what it's like to undergo a thyroidectomy. Thyroiditis, on the other hand, and I've talked about it just a little bit already, that's an inflammatory process affecting the thyroid gland. It's thought to be caused by things like viral or bacterial infections or even fungal infections. And you can have subacute forms or acute forms. Typically what we see is that abrupt, sudden onset, and the thyroid gland is actually painful to touch, painful to palpate. There's something that you'll see, and often is a good example that you'll see on the NCLEX, is Hashimoto's thyroiditis, or a chronic autoimmune process. And we talked about autoimmune process already a little bit with thyroid, but that leads to hypothyroidism. Hashimoto's thyroiditis, that's chronic autoimmune disease, just like we talked about with hyperthyroidism. And the tissue, the thyroid tissue, is actually replaced by lymphocytes and some fibrous tissue that keeps that all together. And it's the most often cause of when we have a Goitre's hypothyroidism. It's important to recognize that often we see a postpartum thyroiditis, and we can see something called silent thyroiditis, where there's really no apparent signs and onset is difficult to nail down. I apologize, not COVID. So let's talk about hyperthyroidism. Hyperthyroidism is characterized by hyperactivity of the thyroid gland with sustained increase in the synthesis and release of those thyroid hormones. Thyroid toxicosis, remember that was at the end of that continuum. It's a clinical syndrome of hypermetabolism, and that's caused by excess circulating levels of T4, T3, or both. And that hyperthyroidism and thyroid toxicosis usually occur together. However, sometimes what we see in some forms of thyroiditis, thyroid toxicosis can occur without that hyperthyroidism. So you have to watch for that. But typically when we have that thyroid toxicosis, we have it in the situation where you already have a hyperthyroidism. Remember, this is also much more common in women, and the age group we're looking at is typically 20 to 40. Let's see, what else can we talk about? We talked about Graves' disease already. I think I covered that pretty significantly. I want to talk for a second about thyrotoxic crisis. And that another name for that is thyroid storm. It's an acute, rare condition in which all of the hyperthyroid manifestations are intensified. So you're not just hyperthyroid, it's like you're hyperthyroid revved up, incredibly revved up. It's a life-threatening emergency, but if we recognize it early and treat it early, we typically can save lives. It's thought to be caused, interestingly enough, by stressors. Heaven knows, many of us can appreciate that. Things like infection or trauma, even surgery as a stressor, in a patient, again, with that pre-existing hyperthyroidism. So the kinds of symptoms we see: severe tachycardia, heart failure, shock, hyperthermia, so very high temperature, well above 40, restlessness, agitation. Patients can have seizures, a terrible abdominal pain, nausea, vomiting, all those GI symptoms, diarrhea. Patients can easily become delirious and often move to coma quite quickly. So in our treatment, what we want to do is reduce that circulating thyroid hormone, and important to make, to provide supportive therapy to help our patients manage with respiratory distress, providing them with physiological support for that, even certainly to the point of intubation. We want to reduce their fever. We want to provide some fluid replacement. Remember, their metabolic system is just completely revved up. And we want to remove those initial stressors, right? Let's carry on with that just for a second. So the overall goal in our treatment of hyperthyroidism is to really block the adverse effects of that thyroid hormone and to stop that oversecretion. 3 primary treatment options are available for patients, and they are antithyroid medications, radioactive iodine therapy, and then that subtotal thyroidectomy. In general, the treatment of choice in non-pregnant adults is that radioactive iodine therapy, but it's influenced, that choice is influenced by a lot of things: how old the patient is, how severe the disorder is, what kind of complicating features do we have, including should they be pregnant, and what the patient chooses to undergo in this situation if all things are equal. If surgery is going to be performed, typically we would still go ahead and give those antithyroid drugs and even iodine. And what that does is bring the thyroid back into that euthyroid state, that neutral state. We might even give something like beta blockers to manage if their heart is racing. So those antithyroid drugs, do you remember we saw a slide a little bit further back there, are propylthyrosol and tapazole, or methimazole. Propylthyrosol and tapazole or methimazole. And we're using those drugs for the effect of bringing down that level, suppressing that level of thyroid hormone. We also sometimes give beta blockers like propranolol. That in radiation therapy, we're going to give that radioactive iodine. Surgery, we would do that subtotal thyroidectomy. We're going to, for nutritional therapy, remember our metabolic system is revved up. So we want to give somebody a high calorie, high protein diet with frequent meals. Let's think. Nursing assessment and planning for patients with hyperthyroidism. What do you think about vital signs? Vital signs, let's say they're ordered Q8. Would you follow that routine? We wouldn't, because a patient needs to be monitored much more frequently. We would typically see an increase in heart rate and an increase in blood pressure. Remember, we're going to assess the patient, and that we can typically feel that thyroid enlargement. There can be diffuse enlargement, right? So if it's the isthmus or the lateral lobes, and when there's no nodules, we'll feel that diffuse enlargement. We talked about Graves' disease, and that's diffuse enlargement. We talked about Hashimoto's thyroiditis, that's diffuse. But if we have a single node, we can palpate that in one single place. That typically represents something like a cyst, a benign tumor. Sometimes we have a node that is just completely benign, but we watch because that may elevate the risk later for a suspicion of malignancy. We also want to look at risk factors: radiation exposure, if we see rapid growth, things like that. If we're looking at that Hashimoto's thyroiditis, we really want to see how firm that thyroid feels, and we really want to watch as well with the malignancy, whether we see that. So again, I'm going to say our goal in hyperthyroidism is blocking the adverse effects of those thyroid hormones and stopping that oversecretion. And so we've gone through that and our choices. Let's look at post-op care. Here's a video, really important that we're going to watch for hypocalcemia, right? Because our parathyroid gland and our thyroid gland are intimately related. We can see that process of calcium leaching happen, and we can move to hypocalcemia. It's important that when a patient undergoes thyroidectomy, whether it's a full thyroidectomy or nodular removal, we want to assess our client every couple of hours, 2 hours minimally for the first 24 hours. We want to watch for hemorrhage, so check underneath the dressing, but also tracheal compression, really significant. We've got an airway at the bedside, and we are prepared for that. We're going to look at neck swelling. We're going to look for signs of any kind of difficulty breathing. Watch for swallowing, including frequent swallowing, that feeling by the patient of fullness at the incision site, if they feel like they're choking, and if we see any blood on the dressing, either posterior or anterior. If the patient is experiencing any distress, we're going to put them in a semi-Fowler's position. That's a position of greater comfort. We want to support their head with pillows and avoid flexion. We're going to monitor their vital signs and complete our full assessment. Watch if, unless we see any of those negative things, we're going to watch for hypocalcemia. And one of the good cues for that, we should be watching our lab results, but we can see tetany as well. And both of those secondary to hypoparathyroidism. So you can have tingling in your fingers and your toes and around your mouth and muscle twitching. So you want to watch for those. And we're going to watch for trousseaux. We're going to check trousseaux and Chvosek sign, and those should be monitored for sure for the first 72 hours, keeping a close eye on it. Now, some hoarseness can be expected in the first 3 to 4 days because of edema. We want to watch management of pain. We've talked about this in lots of different ways, but post-op recovery is really, should be uneventful, but really also tied to good pain management. The patient should be ambulated within just a couple of hours of surgery. They should be able to take fluids as tolerated and eat a soft diet by the next day. Now, patients often don't like the appearance of that incision because it's right near their face, right at their neck. They can be reassured that that scar, and I bet a lot of us know people who have had a thyroidectomy or some kind of thyroid surgery, that scar will fade in color, and eventually it tends to look just like your neck and is buried in a little bit of a wrinkle. It's easy to cover up with a scarf or other things as well. Discharge teaching following surgery is important. Client and family need to be aware of all those kinds of things that are typical for all surgery, but also that idea of how they're going to manage thyroid hormone, and that they'll have to periodically be monitored with that. Most clients experience a sort of a short period of relative hypothyroidism shortly after surgery because we've reduced that thyroid size so significantly. And then the tissue that's left usually hypertrophies. So it recovers its capacity to produce that hormone, but that takes a fair bit of time. And so the administration of thyroid hormones tends to be avoided for a little while because exogenous hormones inhibit that pituitary production of TSH and delay that. We want to make sure that they have a solid nutritional intake. But remember, pre-op, when they were so hyperthyroid, we're giving them high protein, high calorie dense foods. Now we're going to be able to reduce that calorie count to typically within normal limits. Make sure they have adequate iodine. And typically all of us need, all a patient would need is to know to use iodized salt, which is how we get it most often in Canada. The client's going to be seen biweekly for a period of time and eventually move to semi-annually and have their blood checked for the level of thyroid hormones at the same time. So let's talk for a second about hypothyroidism. So it's really important that we keep in mind that the process of managing our patients with hyperthyroid and hypothyroid symptoms can be challenging, that it's necessary that we watch both their clinical symptoms, the manifestations that we see, as well as their experiences, just their own description of of the symptoms. Now, I'm going to bring us back to that hypothyroidism and the etiology. And just the same as hyperthyroidism was too much circulating thyroid hormones, hypothyroidism is going to be insufficient, right? Insufficient circulating thyroid hormones, and a lot of things can cause that. Most commonly, what we see is destruction of that thyroid tissue, or we can have sort of hormone synthesis, but it's defective hormone that we're synthesizing. As well, because again, there is that relationship between our pituitary gland signaling our thyroid function. If we have pituitary disease with decreased secretion of TSH, we'll see that hypothyroidism as well. Sometimes we can see a transient hypothyroidism that can be related to thyroiditis or discontinuation of thyroid hormone therapy. And again, iodine deficiency, the most common cause of hypothyroidism around the world. And in Canada, the most common cause of primary hypothyroidism is atrophy of the thyroid gland. So iodine deficiency is not seen in Canada because iodized salt is the kind of table salt that we use here typically. And so instead what we see as the cause is that atrophy of the thyroid gland. And that results in what we've talked about a little while ago, Hashimoto's thyroiditis and Graves' disease. And again, autoimmune diseases that destroy the thyroid gland. Surgical removal of the thyroid gland or radioactive iodine therapy may be used, and drugs such as amiodarone, which has iodine, and lithium, which blocks that hormone, are relevant and helpful. When we're talking about clinical manifestations, decreased heart rate, so a slower heart rate, increased respiratory rate. Often patients come saying that they've gained weight. They feel constipated, they're really tired, hard to get up out of the chair, and they feel sort of sluggish, mentally lethargic as well. When we're looking at complications, again, it's not just the mental sluggishness, but that physiological sluggishness. They feel drowsy, lethargic. When we're looking at our diagnostic studies, TSH and T4 are the critical labs that we want to look at for hypothyroidism. And thyroid replacement is really important under our collaborative care. So thyroid hormone replacement requires that we monitor those levels and that we titrate the dosage to the patient's requirement. And a patient may be on a certain dose for ages, for years even, and suddenly require a change in the dose of their thyroid medication. Important that now when we've got hypothyroidism, we consider nutritional therapy that's going to help a patient to lose weight. So remember, your thyroid is managing how your system revs up or slows down. As your system slows down, fewer calories are required to maintain your weight. And so often patients are, again, primary symptom may be a patient who arrives saying, I just can't lose weight, I've gained weight and I don't know why. Here's a picture of a gentleman very classically with that swelling in his neck, but a swollen face as well in that hypothyroidism. There is a case study for you on Blackboard, and you can look at hyperthyroidism through that case study. And I think I'm going to stop here. I think this is long enough, and I will record one more lecture where we look at diabetes and chronic complications.